So I'm very excited to have my friend and colleague, Aimee Faso, join us this afternoon to talk with us about oral chemotherapy, prescribing, monitoring, and safety. So Aimee Faso, here is her full professional bio. To highlight, she is a preceptor to pharmacy students and pharmacy residents. She is a clinical assistant professor in the School of Nursing, where she teaches oncology, pharmacology, and the nurse practitioner program. She is an adjunct faculty at Eshelman School of Pharmacy, where she teaches breast cancer treatment to pharmacy students. In 2014, she joined the Lineberger's outpatient breast oncology team, and forever I will not let her forget that she left the GI team. And since 2008, she is a clinical pharmacist practitioner at the North Carolina Basnight Cancer Hospital. So thank you, Aimee, for joining us today. Outside of your professional bio, something personal you'd like to share with our audience today?
Sure. I guess my hobby actually is baking, so that's something I love to do. And with a family who has a sweet tooth, they love that I do that too.
That's great. Do you have a specialty?
I actually like to make French macarons when I can.
Oh,
Okay.
Nice. So here is a sample of a poll everywhere question. You will have a chance to practice in a moment. Our first example is oral chemotherapy is a drug, normally a tablet or capsule, used to help kill or weaken cancer cells. The drug can be taken at home versus in a hospital setting. True or false? This is our disclosures for today. So our poll everywhere question, we have 100% true. How'd they do, Aimee?
They did great.
Great job. So now I will turn it over to Aimee.
All right. Thank you so much, Tammy. It's a pleasure to be able to talk to you about oral chemotherapy, prescribing, monitoring, and the safety. So what I hope you will gain over the next 50 to 60 minutes is that you'll be able to describe the factors that are involved in safe prescribing of oral chemotherapy, review how to appropriately monitor patients while on oral chemotherapy, and then discuss the safe handling, storage, and disposal of oral chemotherapy. So like that first poll question alluded to, oral chemotherapy is a medication that's taken by mouth. These medications are either cytotoxic or they target proteins, pathways, or receptors that are involved in cancer. And the use of oral chemotherapy has been steadily increasing over time. If you just even look at from 2020 to 2022, that actually 18 novel oral chemotherapy drugs were approved. And it is thought that a third of drugs that are actually in the pipeline are going to be oral chemotherapy. So using oral chemotherapy is really shifting care of patients from the provider to the patient. And there are definite benefits to this, but there are some concerns with this change. So the benefits, one is that it's convenient for the patient. So now patients can be at home when they're administering their medication. It's also empowering because it puts the ability for them to administer the medication. It can reduce burden of care. So now patients, instead of making multiple visits to an infusion clinic, are actually doing that at home. And efficacious. So oral chemotherapy, we are not compromising efficacy. So these medications can be very effective at treating cancers. And I have reduced toxicity with a question mark. This can or cannot be true. Some oral chemotherapy, despite being a tablet or capsule that patients take, can have multiple side effects, so it's not necessarily a reduction in toxicity. Now, concerns, one concern that we have is adherence. So when you have patients go from taking medications that are administered by a provider in a clinic to taking it at home, we now have to know that patients are taking their medications appropriately and when they need to. Other concerns can be the safety of the patient and their family, proper storage and handling. Also, are patients being monitored appropriately when their treatment is at home? And then finally, cost, and this is something that we'll discuss later. So oral chemotherapy is used in a wide variety of cancers. So everything from hematological malignancies like CML all the way to like advanced colon cancer. And so since there are so many oral chemotherapies, I can't talk about each of these and how they should be monitored or specifically. However, so I'll be discussing it more generally and providing you information to look up specific information on drugs that you're giving to patients. So when we look at the mechanism of oral chemotherapy, we can see that it's varied. So they can be cytotoxic, like capecitabine. They can be targeted therapies, like imatinib. Endocrine therapies also fall into this category, like tamoxifen. And then there's other mechanisms, the prime example being lenalidomide. So let's first focus on oral chemotherapy and safe prescribing. So when prescribing oral chemotherapy, it's really important that actually institutions have practices or policies in place to provide an environment that can enhance and maintain safe prescribing practices. And that can include standard ordering practices, as well as standardized patient monitoring and standardized symptom management. Consistent documentation is also very important because now as patients take these medications at home, it's important that if they see other providers, that there is good documentation in order to help other providers understand the treatment that patients are taking. Now, looking at safe prescribing, there are certain factors that should be reviewed upon the initiation of oral chemotherapy. So some of these factors I've listed here. So they can include diagnosis, for example, the comorbid conditions that patients have or their past medical history that could have an influence on what drugs are prescribed or decided to not be prescribed. A comprehensive medication history and drug allergies is also important, as drug interactions need to be determined because that can affect dose, for example. Height and weight, as some drugs are flat dose, but some drugs actually are based on height and weight calculations. The functional or performance status of the patient is also important. That determines how they may tolerate the drug. And then baseline labs, which will be determined depending on the drug, because that can affect dose as well. And then finally, at subsequent encounters with these oral chemotherapies, there's multiple factors that need to be considered. So for example, their vital signs, as well as the patient's weight, any new allergies that may have developed since you last saw them, of course, toxicities, so for side effect management. Medication review is also important to review upon each visit, since patients can have started medications either outside of your institution or perhaps started over-the-counter medications, and those can have drug interactions. If there's any change to their patient's functional status, is important to assess at each encounter, and then finally, any labs as appropriate for the drug. So the actual prescription, I've included the factors that are important to include, and some of those, and I have an example for capecitabine here. So patient name and demographics is obviously important to include, and as well as the drug name. It helps the pharmacist if you can include the drug calculation, if that is a necessary part of the prescribing, since that allows the pharmacist to do the double check and make sure that the final prescription makes sense. If you can, including the schedule, especially when drugs are cycled, as well as administration instructions, is also helpful for the pharmacist to do the double check, but also for that information to be included on the prescription for the patient. And then finally, quantity and refills are a necessary part of any prescription. So when patients are being prescribed oral chemotherapy, an important factor in that new prescription is going to be patient education. So all patients should be provided education prior to the start of new therapy. And it is best to use standardized teaching materials because that way whoever is providing the education can provide consistent information from patient to patient. It's important that the education and the education materials are suitable for the health literacy of the patient, as well as provided in language appropriate for the patient. One thing that's important about the education is that it can clarify patient misconceptions. So patients may feel that because it's a medication they're taking at home, that it doesn't have any side effects. And this is the opportunity for you to clarify what potential side effects could occur. And then finally, patient education often needs reinforcement throughout the entire treatment period. A lot of times patients are getting so much information in their clinic visits or in follow-up visits that the information can be overwhelming, and hearing it more than once is always helpful. So when providing patient education, I've listed here some of the important things that should be reviewed for that patient education session. So the diagnosis and why they're getting the medication is important, as well as the goal of the treatment. Going over those specific administration instructions, and as well as how long it's expected to be on the treatment. Is it a 6-month treatment, or is this until they have disease progression? Other important things to discuss include monitoring and how you will do follow-up with a patient so that they know what the expectations are. And then side effects, of course, are important to review, and not only what side effects to expect, but also if patients can self-manage, what kind of things that they can do to treat or help those side effects. And ultimately, what's important is that patients know when they need to seek medical attention, since now patients have to monitor themselves when they're at home. They have to understand what variables require a call to the clinic, or perhaps even an emergency room visit. So when providing patient education, having information in writing is really important. And anything that you can provide to help make the plan actually more comfortable for the patient and clearer is always going to be helpful once they go home. And it's always good to have something that they can refer to later. So for medications that have different administration instructions, writing that out specifically can ensure that the patients take it correctly at home. So the example that I have here is the regimen with lapatinib and capecitabine. So lapatinib has to be taken on an empty stomach. And so in this example, the provider and the patient decided that they would take their lapatinib an hour before they had breakfast each morning. So they would take their lapatinib at 7 in the morning and then have breakfast at 8 a.m. And since capecitabine should be taken within 30 minutes of a meal, they would take their capecitabine dose in the morning at 8:30 in the morning, and then they would take their evening dose 30 minutes after their dinner, so at 8:30 p.m. So writing this out specifically can be a great help to ensure that patients take their medications appropriately. Now, some of the regimens that patients have to do are very complicated. They can involve multiple oral chemotherapy drugs, and even include IV therapy as well intermittently throughout the treatment period. So some patients will need a calendar, and this is just an example of one patient who had a very complex regimen. It was actually written out specifically day by day what they needed to take in order to help ensure that they took their medications appropriately. So when providing patient education, the information should be reviewed verbally, and it should also be in written form. That way, patients have something to refer to after they leave the visit. Also, if you can involve the caregivers or family members, that can also be really helpful. That can help the patient be more successful to take the medications correctly at home as well, if they have those to support them with taking those medications. And then it's always good to encourage patients to write information down, taking notes. If they have questions, write down those questions and write down the answers. That way, after they leave the visit, they can refer to what they've written. So where can you find patient education resources for your patients who are starting oral chemotherapy? So there's multiple actual websites that provide free handouts for patients, and I have 3 of those listed here: OncoLink, ChemoCare, and Oral Chemotherapy Education. These 3 sites provide patient handouts for free, and they're available in English as well as Spanish. And these can be very helpful for patients to take home in order to review after they've talked to the providers. If you need information, so things that are more geared for the healthcare practitioner, there is the package insert. This provides a lot of information, and some package inserts even have a specific page that lists what should be discussed with patients. And then there's the tertiary drug information databases. So these are the databases that have the specific information about drugs that is actually geared for the healthcare practitioner. And these can include things like LexiComp or Micromedics, which are available at your institution. If you don't have these resources, then there's others that are available for free that are specifically geared for the healthcare practitioner, but have good, trustworthy information. So drugs.com is one. Another is Daily Med. So these are ones you can refer if you don't have one at your institution or not at your institution when you need to look up drug information. So safe prescribing also requires looking at specific drug interactions, because oral chemotherapy can interact with medications, supplements, or foods. And it's important to assess these interactions because that can affect either the toxicity of the drug or it can affect the efficacy. And it's important to know that up front so their changes can be made as appropriate. There's multiple mechanisms that can cause these interactions, and we'll talk about those in just a moment. But it is important that you assess for these interactions at each visit, since patients can start new medications really at any time. And don't forget those over-the-counter medications or medications that they get without a prescription, because those can have interactions as well. One difficulty is sometimes assessing for interactions, and while our drug databases can be very clear on what interactions potentially may occur, sometimes they're not always clear on how you should manage them. So that's one of the challenges that we have with drug interactions. So one type of drug interaction is a pharmacokinetic drug interaction. So this is a drug interaction that affects the absorption, distribution, metabolism, or the excretion of another drug. So I think a good example of this is looking at the enzyme CYP3A4. So CYP3A4 is a common enzyme that metabolizes many medications, including many oral chemotherapy drugs. Drugs that affect this enzyme, either induce it or inhibit it, have the potential to change the concentrations of drugs that are a substrate of this enzyme. So for example, looking at phenytoin, this is a strong 3A4 inducer. So what that means is that it can significantly decrease the concentration of medications that are a substrate of this enzyme. Whereas actually Paxlovid contains the ingredient ritonavir, and this is a strong 3A4 inhibitor. And what that can do is increase the concentration of drugs that are metabolized by CYP3A4. So that's why, for example, patients who have to be treated with Paxlovid for their COVID may have to stop their oral chemotherapy because of this potential drug interaction. There's also pharmacodynamic drug interactions. So these are interactions that can lead to either an additive, synergistic, or an antagonistic effect. So one example that I like to go over is a QTC prolongation. So some oral chemotherapy can prolong QTC, and if you give other drugs that also can prolong QTC, then you've really increased the patient's risk of that prolongation. So one example is ribociclib. This can cause QTC prolongation. So if a patient is on ribociclib, but then also is on ondansetron or citalopram, which can also prolong QTC, then you've increased the risk of that prolongation. So it's important that those patients have EKGs monitored in order to assess whether they are at risk. Other interactions have to do with acid suppression. So for many drugs, acidity in the stomach is very important for proper absorption. But we give drugs specifically to reduce absorption, like proton pump inhibitors, H2 blockers, or antacids. And for some drugs, reducing that acidity can affect that absorption. So for example, with proton pump inhibitors, actually there are certain drugs such as dasatinib, erlotinib, neratinib, which will actually have a decreased absorption in the presentation of PPI, and therefore that combination should be avoided. Looking at H2 blockers, there are certain drugs that need to be separated in time from H2 blockers so that their absorption isn't affected, and nilotinib being an example of that. And then some over-the-counter antacids should also be separated in time from drugs because of affecting their absorption. So anything from orlotinib, for example, or neratinib, these are just some examples of that. So herbal supplements can also have important drug interactions, and these can either be pharmacokinetic or pharmacodynamic. So unfortunately, it is very difficult to always assess just because there's not a lot of data on many herbal supplements and what these potential drug interactions can be. But just because it is an herbal product doesn't mean that it doesn't have these significant interactions. So one example is St. John's wort. It is a CYP3A4 inducer. So since that potentially can decrease the concentration of drugs that are a substrate of CYP3A4, it would be recommended to avoid this combination. And also food can interact with certain oral chemotherapy. Sometimes it can improve absorption, or sometimes it can decrease absorption. So each drug has its own specific instructions as far as if it should be given with food, without food, and some drugs it doesn't matter, it can be with or without food. So for example, some drugs must be administered on an empty stomach. It's important to look at the instructions because empty stomach can be defined differently depending on the drug. But one example I have here is lapatinib. And so they define an empty stomach as 1 hour before a meal or 1 hour after a meal. Then there are medications that should be given with food. So capecitabine being one where it should be administered within 30 minutes of a meal. Regorafenib is one that has specific instructions that it should be taken with a low-fat breakfast. And then finally, grapefruit. This is a common food that patients often are told to avoid because actually it's an inhibitor of 3A4. And so since many of our drugs that we use are substrates of 3A4, we usually recommend to avoid this combination since that can affect concentrations of the drug. So where can you find drug interaction resources for certain oral chemotherapy drugs? Well, the package insert has some information. It may not be complete, but it can be a good start. The tertiary drug information resources that I've listed here, such as LexiComp or Micromedics, or those free sites like drugs.com, they have very useful information, and they allow you even to type in all the drugs the patient is taking, and it will give you recommendations of those potential drug interactions. Now for herbal information, this can be a little bit more challenging, but there are some good resources available. So Natural Medicines is an excellent resource. It's available usually through libraries or institutions. If you don't have access to natural medicines, then I really like the Memorial Sloan Kettering website called About Herbs. This is a free website, and they have information that you can print out for patients, and they have information that is geared for healthcare practitioners and can help when making decisions about drug interactions. There's also the National Center for Complementary and Integrative Health. This is a more general website, more geared for patients, but that's something that you can refer to or tell your patients to refer to if they have questions. So when talking about prescribing oral chemotherapy, we have to talk about how ultimately the drug gets to the patient. Because that is really the most important piece, that the patients get their medications. And with oral chemotherapy, most of these drugs have to be dispensed by a specialty pharmacy. These are pharmacies that are designed to provide oral chemotherapy or other medications that are either for complex diseases or that are expensive. And most specialty pharmacies are mail order. So let's take a look at what steps are involved once a prescription is written and getting this medication to the patient. So first you write the prescription. Now, once the prescription is written, it needs to be determined where the patient can get the medication from. Like I said, most patients have to receive their medications from a specialty pharmacy, and this is determined by their insurance company. And insurance companies will have usually specific contracts with specific specialty pharmacies that must be used. Now, a subset of oral chemotherapy drugs have a limited distribution. And what this means is that there's only several pharmacies within the nation that can actually distribute the medication. So one example are the drugs from Celgene that include lenalidomide, pomalidomide, and thalidomide. So once the prescription is written, what's really important now is that a prior authorization through the insurance must be performed. And there's multiple ways that you can do that. Some places have staff who can do this, and it's either through an online portal or actually calling the insurance company. The turnaround time for prior authorizations can vary greatly depending on the insurance company. And so sometimes it can happen as early as 24 hours. Sometimes it can take 120 hours or more. When prescriptions are written for things that are off-label, meaning not FDA approved, or if you are not following the insurance company's criteria for that particular medication, that means drugs can be denied and not authorized. So once the medication is authorized by the insurance company, unfortunately, copays can still be expensive. These medications are usually in the highest tier of the insurance company, and sometimes they're actually placed in what's called a specialty tier, which usually has a higher copay than the other tiers in the plan. And most patients actually will need probably copay assistance for these medications. One study that looked at a Rhode Island pharmacy that was associated with an academic center, over a 3-year period, about a third of patients did need financial assistance, but patients who were over 65, almost half of them needed assistance. So it's important that we address this, and we'll talk more about that in just a moment. So once the prescription is authorized, once it's determined that the copay is doable for the patient, then the pharmacy will call the patient in order to set up delivery. And then finally, that prescription is mailed to the patient. So the thing that I wanted you to notice is that there's multiple steps that happen from the time the prescription is written till the patient actually receives the medication. And sometimes the provider is left out of these steps, so they may not even know that there are any problems. And the problems that can happen at any of these steps just means a delay in patients starting that prescription. So it's important that we address cost. I've alluded to this as I've been talking, that these drugs can be expensive. And looking actually at some data, the US patients paid an estimate $16 billion of out-of-pocket costs and lost nearly $5 billion in costs related to time in 2019. And during the first year of a cancer diagnosis, these out-of-pocket costs can be thousands of dollars. So for patients who were 65 and older, they had an average of $2,700 in out-of-pocket costs. And patients who were younger, so less than 65, had an average of $5,900 of out-of-pocket costs. So these are huge costs that place a burden on our patients. So what can we do to help patients with these high drug costs? Well, part of it depends on how they're insured. So for patients who are uninsured, there are manufacturer assistance programs that can provide drugs for free for these patients. So this is something that we try to make sure that these patients have access to. For patients who have commercial insurance, they can use copay cards most of the time. There are charities that have grants that provide copay assistance that can be very helpful when those grants have funding. And also for patients who are underinsured, they can be eligible for manufacturer assistance as well. Now, patients who have government insurance, such as Medicaid or Medicare, they are not eligible for copay cards, but there are some grants available for patients who have Medicare Part D plans, and some of these patients can have access to manufacturer assistance as well. So what are some resources that you can access to help patients with cost? So I have listed here some of the charity grants that we tend to use most often, and they provide copay assistance based on disease state. Needy Meds is actually a website that just can help you find resources for a specific drug. So it lets you look up that specific drug, and then it'll list what resources are available. Some resources are actually available to organizations that help a specific disease state. So patients can go onto these websites and look and see if they have resources available, such as the Leukemia Lymphoma Society. And then don't forget about pharmacists. We are here to help, and often we can have availability of resources that we can offer patients. So that brings us to our first poll question. So the question is, which of the following is not the best resource to determine potential drug-drug or drug-herb interactions with an oral chemotherapy medication? So is that the medication package insert, those tertiary databases, TikTok, or the Sloan Kettering About Herbs website?
So I don't see answers coming through right now, but hopefully our audience knows which one this is.
Yes, so hopefully, if you've tried to answer, you would have chosen TikTok is not the right resource to look at drug interactions, but the other three obviously being good resources.
All right, and this is Tim. If that happens again, we're going to try to do a quick reset in there. But for now, let's go ahead and go on. Thank you.
Mm-hmm. Okay, so let's move on now to safe monitoring of patients who are on oral chemotherapy. So oral chemotherapy can have many potential side effects. And really, the potential side effects is based on the mechanism of the oral chemotherapy. So for drugs that have a cytotoxic mechanism, monitoring is going to be important for kidney and liver function, as that can determine the dose that we need to use. Also, these agents tend to be myelosuppressive, so that's a common side effect with the cytotoxic agents. With our targeted therapy, for monitoring, obviously kidney and liver function is still important, but they have many potential side effects, and so that means different labs that may need to be monitored. So for looking just a little bit more specifically at targeted therapy, so the side effects that can occur from these agents will depend on what their target is, but they're on target, but they can also have off targets. So meaning those other targets that aren't necessarily what's used for efficacy. But because that can be really any system within the body, it really is specific for the drug as to what needs to be monitored. So those potential labs or tests that may need to be monitored can include everything from a CBC and LFTs and serum creatinine. Also, some drugs may require EKGs or blood pressure checks. So it really depends on the drug itself. So where can you find lab testing and how often these labs should be performed? Actually, a great place to go is the package insert. So in the warnings and precautions section, this is often where drug companies will put what labs need to be monitored and how often. But you can also find this information in those tertiary drug information databases like LexiComp or Micromedics. So I just have an example here. This is imatinib, and this is listing what those labs or tests should be. So this specifically lists what should be tested before patients start, and then finally after patients start, what should be monitored and how often for continued patient monitoring. So I know this is a busy slide, but I just wanted to give the example of depending on the drug will really depend on what labs need to be monitored and when. So all of these drugs are used for CML. They all are tyrosine kinase inhibitors that have the same target. But as you can see, even though they have the same mechanism and have the same target, they have different labs that are required. And so you really have to look specifically for that drug. And just another example, again, these are 3 medications that have the same mechanism and the same target, but require different lab monitoring. Now, with monitoring patients, adherence is very important. And what we mean by adherence is the degree or extent of conformity of the recommendation about day-to-day treatment by the provider with respect to timing, dosage, and frequency. In other words, are patients able to take their medication appropriately, the right dose, the right frequency, the right time? Because if patients are not able to take their medications appropriately, this can lead to either poor outcomes for the patient, it can lead to increased toxicities or even increased care costs. So looking at the consequences of non-adherence, so it's what we have found with some really important studies is that patients who are not adherent to their oral chemotherapy may be compromising efficacy of the drug. So this is one study that was done in women who were diagnosed with hormone-sensitive breast cancer, and they were prescribed 5 years of adjuvant endocrine therapy. And what they found was that actually about a third of them did not take the medication for the 5 years as expected. And of the women who did take it for the 5 years, 28% of them were non-adherent, and they defined that as being taking less than 80% of the doses that were required to be taken. So looking at the figures on the right-hand side, looking at A, you can see that there is the blue line. This is patients who actually took 5 years of the endocrine therapy. When compared to patients who did not take it for the 5 years, they actually found that patients who took it for 5 years had increased survival. And then for the patients who took 5 years of endocrine therapy, they then looked at patients who had taken it less than 80% of their doses versus more than 80% of their doses. And that's shown in figure B. So the patients who took more than 80% were adherent, and that's in the blue line, and patients who took less are the red line. And again, patients who took more than 80% of their doses had improved survival compared to those who did not. Another important study was done with imatinib. So patients with Philadelphia chromosome positive CML have a chromosomal abnormality. And we treat this with agents such as imatinib, which can greatly reduce this chromosomal abnormality. When we greatly reduce that patient's chromosomal abnormality, we call that a major molecular response. And so our goal for these patients is to achieve a major molecular response. So there was a study that was really looking at, there were some patients who were on imatinib who did not seem to be able to achieve this major molecular response. And what they found was that actually non-adherence was a factor. And I think this figure really illustrates how important that is. So they defined adherence as taking greater than 90% of their doses, and that's reflected in the blue line in this figure. Whereas patients who took less than 90% of their doses were significantly less likely to achieve that major molecular response or a successful treatment from their imatinib. So there are many factors that are related to non-adherence. They can be anything from patients having many side effects, which can make them less likely to take the medication, to having complex regimens that are just difficult for the patient to understand, to having socioeconomic factors, so perhaps they can't afford their medications. So one or more of these can apply to a patient. So it's important to, when monitoring patients on their oral chemotherapy, to assess whether they're adherent. And asking just one question can be a way to assess that. So since I last saw you, how many doses of your medication do you think you have missed? That can help you determine whether patients are having issues with adherence. You can also look for certain factors which are indicative of non-adherence, such as missing appointments or not filling prescriptions. Having multiple adverse effects can increase non-adherence. Those high medication costs, if patients can't afford their medication, right, then they're not likely to be adherent. Also, if patients don't understand their treatment, and this is where providing consistent patient education throughout their therapy is important. And finally, there are psychological factors that can be involved. So patients who are depressed, for example, are less likely to be adherent. So what are some things that you can do to help patients be more adherent? Sometimes patients just forget, and helping patients to remember can include telling them to use alarms or helping family members to remind them to take their medication. With side effects, if patients have more side effects, they're likely to have more non-adherence, and that's where managing patients and observing them closely can be important. Again, patients having questions, that re-education so that patients understand what they're taking and why is important and that not only is important for them to understand what they're doing, but that helps them to be successful with adherence. Cost, again, for those drugs that are high in cost, trying to provide resources to help pay for those medications. And then finally, for complex regimens, if there's anything that you can do to help it make it easier once they go home, or even if there's ways to simplify the regimen, that can help patients adhere. Okay, so let's go to the next question. So which of the following is a sign of non-adherence to a medication? So the patient tolerates the medication with few adverse effects. The medication has a high cost. The patient is engaged in his or her treatment, or prescriptions are filled regularly and on time.
All right, and if you'll bear with me for just a moment, we're going to go ahead and restart this and see if we can get Poll Everywhere to work properly. My apologies. There's usually something that acts up. All right, so we'll go ahead and let's see, we're on slide 66. And we'll see if we can bring that back. And thanks for everyone's patience. We'll bring back the slides in just a moment, and we'll see if we can get Poll Everywhere to work. Well, darn, we gave it our best,
Yeah.
and unfortunately, it looks like I don't want to delay things any longer, so it looks like it's not cooperating, so we'll let you take it. You did a great job with covering for the last one, and we at least we tried.
Okay, so although Poll Everywhere isn't working, but I'm sure that most of you were able to identify that medications that have a high cost can it be a sign of non-adherence. Okay, so now let's look at safety when it comes to oral chemotherapy. So not all healthcare professionals actually have to come into contact with oral chemotherapy. But for those who do, it is important for them to receive training on safe handling of oral chemotherapy, and it's important that they follow the institutional policies as well as guidelines that are necessary for oral chemotherapy. But for patients, we have to educate them on safe handling of their oral chemotherapy, so it's important that they understand what the instructions. So tablets and capsules, for the most part, with just a couple of exceptions, should not be crushed, chewed, or cut in order to make sure that they are being safe with their oral chemo. Patients may be instructed to either use gloves when administering their medication or to tip the tablet or capsule into a cup and take it from the cup, so as they just reduce exposure to the drug. And washing hands thoroughly is important. I recommend this since if there's any powder or on the tablets or capsules, that way they reduce exposure to the family and friend by not spreading that powder around the house. If patients are able to use a pillbox for their oral chemotherapy, they should not share the pillbox with others, again, to reduce their exposure. And then finally, some do recommend that patients, if they are able to double flush the toilet or to use a separate bathroom if that is possible. Now, safe storage is also really important. I mean, obviously, with oral chemotherapy and with any medication, you want to keep that away from children or pets. But it's also important that it's put in a proper environment. So it shouldn't be in a very humid place, such as the bathroom, or in direct sunlight. So also reading labels is really important because some oral chemotherapy do have specific instructions. So some have to be stored in their original container, like regorafenib, and some oral chemotherapy has to be refrigerated, such as oral etoposide. And then I always tell patients if they are traveling with their oral chemotherapy, it's important that they store it in the original pharmacy labeled container while they're traveling. Now, for disposal of oral chemotherapy, ideally, we want to dispose of that into disposal sites or drop boxes. And oral chemotherapy should not be flushed down the toilet. So not all places will have these drop boxes. Otherwise, if that is not possible, oral chemotherapy can actually be placed in a double sealable bag or in a container that can be sealed and then thrown away in regular trash. Now, one exception is actually the drugs lenalidomide, pomalidomide, and thalidomide. The company Celgene actually provides a container that patients can place unused drugs, and they're mailed back to Celgene so that they can dispose of them properly. So some oral chemotherapy resources that you can use. So there's so many oral chemotherapy drugs. They all have specific instructions. And so if you have questions or want to get more information, I have listed some resources here. So the Hematology Oncology Pharmacy Association, they have really good information about oral chemotherapy, including their education sheets, which are very useful, as well as this outline that I have the PDF website linked to, has a lot of good resources. The Oncology Nursing Society also has a lot of good information, and I've included the link for the oral anti-cancer medication toolkit. But also those institutional sources, tertiary databases provide a plethora of information, but drugs.com, dailymed.com, these are good, reliable resources that are available for free with just internet access. And then finally, don't forget pharmacists. We are always here to help and to provide information for you and your patients. So this takes us to the last poll everywhere question. I guess we'll give that one more try. But which of the following is not recommended to patients for safe handling of oral chemotherapy? Take tablets by tipping them first in a cup. Wash hands after handling oral chemotherapy. Do not share pill boxes with others. Or cut tablets to help make them easier to swallow. So which would we not want to recommend?
Well, and our poll everywhere now is working, thankfully.
So one question.
We've got some mixed answers.
Yeah. So the thing that we would not want to recommend actually is we don't want to recommend patients cut tablets to make them easier to swallow. So the majority of oral chemotherapy should not be crushed, split, or chewed. So things that patients can do to be safe is tipping them into a cup and washing their hands. And then if they're using pill boxes, it's important that they shouldn't share those with others, whether that's family members or friends.
So that was our last poll everywhere question. So if you have questions for Aimee, you can put them into poll everywhere. Hopefully they will pop up. If we have issues, then we can work through the chat, but we'll see how that goes. So get your questions ready, and you can start submitting them.
Okay. Yeah.
Okay.
Yeah. So, so whatever questions you have, I'm happy to try to answer.
So thank you, Aimee. That was great. A lot of helpful information. I think, proving the value of our clinical pharmacists on our teams in providing amazing, safe patient care. So I utilize my pharmacist as a great resource, but thank you for sharing all of those as well. Are there any questions coming through?
Not yet, but we will continue to monitor, and there may be some coming in the next minute or so. We'll continue to wait and see if some come in.
So grapefruit is always a topic of conversation. So should patients avoid it totally or just around medication taking?
So actually eating grapefruit can actually affect the enzyme for several days. So it's really important to just tell patients to avoid it because just not taking it around the time they're taking the tablet can still lead to that interaction. So unfortunately, for those grapefruit lovers, they're always really sad when I tell them. But I also try to encourage them. Oranges, lemons, limes, these are just fine. And so hopefully they can be satisfied with substituting the grapefruit. Yeah, that's a common question.
Yes,
Yeah.
Sorry.
Mm-hmm.
Another question, are there special instructions for patients receiving radiation during their chemo?
As far as the oral chemotherapy goes, I would say there's nothing really specific except that the instructions may change when they're on radiation, so how they take the drug might be different. So Tammy and I work with patients who take capecitabine with their radiation, and those administration instructions are different than if they're not on radiation. But actually how they take the oral chemo isn't changed. Mm-hmm.
Not necessarily a question. Oh, here, let me use the audience questions first. How can you monitor if a prescription is filled or not?
That is such an excellent question, because especially if it's being filled by a pharmacy that's not associated with your institution, the problem is you don't know. And a lot of times you might have to engage the patient in order to determine, like, have you heard from the pharmacy? So oftentimes contacting the pharmacy directly is really the best way to determine what issues there are and if they've been able to send it to the patient. Sadly, there's not a great method. And every specialty pharmacy is different. There's one specialty pharmacy where I can actually log on and watch as prescriptions are being filled, and it's a great resource, but it's just one. Others I have to call.
Yeah, I find that, challenging as well. I think it takes a lot of follow-up between myself, nursing, or pharmacist, calling and checking in with the patient. Lots of times I even will tell the patient, send a MyChart message when you receive your medicine so we know what date you're starting or something. So trying to engage the patient more in their care and communicating with us as a team.
Yes, it can be such a challenge, and the patient hasn't even started the drug yet.
Correct.
Yes. Yeah.
So how does oral chemotherapy taste?
That's a great question. I will say I personally have not tasted oral chemotherapy, but it really depends on the medication. So some oral chemotherapy tastes horrible, and actually everolimus is one. I get a lot of complaints that patients get a metallic taste, and that lingers in their mouth. It's sometimes some of their biggest complaints. So it really depends on the drug. Some don't have any taste, and it's just like taking any other pill. Lapatinib is one where I have so many people tell me it gets stuck in their throat. I don't know what it is about the coating. So it just depends on the drug. Mm-hmm.
And back to grapefruit, which is always a hot topic with our patients. We both experience. I think you answered this. Should one avoid grapefruit for a time around the drug administration or totally?
For the most part, yeah, they should avoid it. I will say sometimes I've had people call me in a panic oh my God, my friend gave me food and it had grapefruit in it, and I had grapefruit that at a buffet weekend. And so I tell them it's okay. That one time is not going to have a significant impact. But taking grapefruit on a regular basis is really what you want to avoid.
That may be our last question. Any last minute questions before we let you all go for the evening? And thank you again, Aimee, for such a great talk and providing such valuable information for us to provide really great care. Thank you to the University Cancer Research Fund, to the UNC Lineberger Comprehensive Cancer Center and the Lineberger Cancer Network, our telehealth team, our amazing team behind the scenes making all this magic happen. Thank you to Tim, Benny, John, Oliver, Andrew, Nadja, and Patrick.